Welcome everyone, and thanks for attending this FRCS teaching session with the FRCS mentor group. The presenter tonight is Ranjit Isaac. He's a surgeon from Leicester. He's recently passed FRCS, and he was going to talk tonight about rotator cuff tears and the relevant points to consider for the examination. Also, we have other mentors in attendance here, Babu and Muhammad Imam, who's also an upper limb surgeon, and they will be here to give a supporting hand to Ranjit and answer any questions you have. I'm Firas. I'll be moderating this session. Please ask any questions in the chat box or raise the hand symbol next to your name if you would like to talk directly to any to the presenter or any of the mentors. At the end, there will be one Viva question, upper limb related Viva question at the end of this teaching session. So if anyone is interested, please make sure you raise your hand to be the candidate. And just a reminder that anyone who would like to have a CPD certificate, 1 credit from the Royal College, is encouraged to get in touch with me to issue you one. Okay, and this teaching will be published later on YouTube channel. The YouTube channel called FRCS Mentor. So thank you everyone, and I will leave you now with Ranjit.
Hello everyone, hi. I want to present on this rotator cuff tears. It's purely for the FRCS. So it's not for a daily, day-to-day practice of shoulder practice, or it's just purely what you need to know for the exam. And for part one, essentially it's the MCQs, and part two, it's basically for the practicals and the vivas. So I'll talk along it as we go through it. So rotator cuff tears, the anatomy, just a basic anatomy. You know that actually with the subscapularis attached onto the lesser tuberosity supplied by the upper and lower subscapular nerves. Then you got the supraspinatus, infraspinatus, and the teres spine attached onto the greater tuberosity, supraspinatus and infraspinatus by the suprascapular nerves. So that's essentially the anatomy. I mean, no one is going to ask that because it's undergraduate level. And rotator interval is a hot favorite for the MCQ because it comes time and time again. So in fact, it's a triangular region which is bound anteriorly by, it is bound superiorly by the anterior border of the supraspinatus, inferiorly by the superior border of the subscapularis, and the base formed by the coracoid. And the contents of the rotator interval, that's the most important part for the MCQ. And the contents are the long head of the biceps tendon, the coracohumeral ligament, the superior glenohumeral ligament, and the rotator interval capsule. And you know that it's a rotator interval which you release in the arthroscopic surgery for adhesive capsulitis. So in part A for the FRCS, it's usually they give you a scenario and then they won't ask you what is the content of a rotator interval. The question would be like a clinical picture, for instance, of an adhesive capsulitis or a frozen shoulder, an arthroscopic surgery being done, going to release a structure, and then they're going to ask you what are the contents of that region. So it's going to be indirect question with regards to rotator interval and the contents of it. So that's a favorite MCQ. And speaking of the rotator crescent, it's a thin crescent-shaped sheet of the rotator cuff comprising the distal portions of the supraspinatus and the infraspinatus insertions. So if you can see my cursor there, so this thin area, which is adjacent to the greater tuberosity, where the supraspinatus and the infraspinatus inserts, this thin area is called the rotator crescent. And just proximal to the rotator crescent, you got something called a rotator cable, which is a thick bundle of fibers which are 2.5 times thicker than the rotator crescent. So it's a thick cable there, which is just proximal to the rotator crescent. And the combination of the rotator crescent and the rotator cable is what you call the shoulder suspension bridge. So the shoulder suspension bridge is formed by the rotator crescent and the rotator cable. I think in orthopaedics they got an arthroscopic picture of this area, and they got an arrow towards the rotator cable asking what structure it is. So essentially this rotator cable and the rotator crescent. And then the rotator cuff is a dynamic stabilizer. It balances the force couples because it balances the force couples formed anteriorly by the subscapularis, superiorly by the supraspinatus, and posteriorly by the infraspinatus and teres minor, and it causes concavity compression. So the buzzword for the exam is concavity compression. So whenever you in the viva situation or the practicals, get a picture of a rotator cuff arthropathy where the humeral head is migrated proximally. The next question would be, why is it so? Then the buzzword that they're looking for would be the concavity compression is lost because of the rotator cuff tear, and that's the buzzword which needs to be said in the exam. So the blood supply, it's essentially to the rotator cuff is by the subscapular, suprascapular, and circumflex humeral arteries. The dorsal side is more vascular than the articular side. The articular side is considered to be hypovascular. And the zone of critical hypovascularity is adjacent to the most lateral portion of the supraspinatus insertion. So that's the zone of critical hypovascularity where you can get a lot of tears. And the causes, if someone asks you the causes, you can, it's always better to classify whatever you say, especially when it comes to causes. So you can classify broadly as traumatic and atraumatic. And traumatic classically follows a fall or a dislocation. And there is this best BOA patient care pathway which says that any patient above 45 years with a loss of shoulder function after a shoulder dislocation, or with more than 4 weeks of shoulder dysfunction after a shoulder injury, should undergo an MRI scan or ultrasound scan to investigate for a possible acute rotator cuff tear. So in essence, if you get a more than 45 years age patient with a shoulder dislocation, then you need to look for a rotator cuff tear. And if it's a younger patient, you're basically looking for a Bankart lesion. And again, the causes like initially was traumatic and atraumatic, and the other causes can be classified as intrinsic causes or extrinsic causes. The intrinsic causes can be related to the age, degenerative, diabetes mellitus, inflammatory causes, and rarely connective tissue disorders like Marfan syndrome. And the extrinsic causes would be like impingement, and the cause of impingement can be again inflammatory causes, and osteophytes at the acromioclavicular joint, calcification of the coracoacromial ligament, or subacromial spurs. If someone asks the cause of rotator cuff tear, it's always good to classify them so that it gives us time to answer the question. Also, like examiners like it when you got a system to answer it. And classification, we got the Caulfield classification, which is described in 1982 as rotator cuff tears into small, medium, large, and massive. Small tears are when it's less than 1 centimeter size. Medium is when it's 1 to 3 centimeter. Large is when it's 3 to 5 centimeters. And massive it's when it's more than 5 centimeters. Or some people say that it's 2 or more tendons which are torn, it's a massive tear. And the classification can also be based upon the cuff tear, the shape of the cuff tear. So it can be a crescent-shaped tear. So a crescent-shaped tear means, can you see the cursor there? Okay, so a crescent-shaped tear means, if you could see it here, you can see that this is the mediolateral length, and that's the AP, anteroposterior width. So the mediolateral length will be less than the anteroposterior width, and then it's called a crescent-shaped tear. And the torn ends, proximal end, will be mobile in a mediolateral direction. That is, you can hold the proximal torn end and bring it back onto the footprint. So then you call it a crescent-shaped tear. And the treatment for that would be a direct tendon to bone repair, as you can see there on the right side. The next type of cuff tear based upon shape would be a longitudinal tear. That's the opposite. So it's typically mobile in the anterior to posterior direction. So you can see the medial lateral length would be more than the anterior posterior width. So it will be very difficult to hold the proximal end and bring it onto the footprint. So what you do initially is you do something called a margin convergence, and that's the buzzword. In a longitudinal tear, you do margin convergence. By margin convergence, what you mean is you suture the tear, which is a longitudinal tear like this, you suture it end to end, and then if possible you bring it onto the footprint. So this is essentially what you call margin convergence. So margin convergence is the buzzword that we need to know. And longitudinal tears can be U-shaped or L-shaped. So as the name suggests, would be a U-shaped one, and this would be an L-shaped one tear. So in both instances, first we will do a side-to-side repair, and that's called a margin convergence, and if possible you bring it back onto the footprint. And you go to the third type of tear, which is called a massive and immobile type of tears, where you do an interval slide, where you do a lot of releases and then you bring it on. So that's the interval slide in massive tears. And of course, there are partial tears. Classification for the partial tears would be an articular side tear or a bursal side tear. So, and that's another way of classifying these tears. And the clinical features, the classical history would be a night pain typically with overhead activities and weakness. So in an exam situation, so you most probably it will be a short case. So when you walk into the cubicle, the examiner would be taking you and be asking you examine this patient's shoulder, or sometimes the examiner would directly tell you like examine the patient's rotator cuff. More probably the examiner would be saying that examine the patient's shoulder. So when you do the inspection, so you ask the patient might be sitting down, you ask the patient to stand up if possible, okay? Ask the patient to stand up. In a short case, the patient might be kept undressed. If it's not undressed, you ask the patient to undress his shoulders. You see both shoulders together. You stand in front of the patient. You start at the inspection. So you say that on inspection, I see that there's a loss of contour. There is wasting. They'll ask you, examine the patient's right shoulder or left shoulder. There might be bilateral findings, but if they ask you, examine the right shoulder, stick onto the right shoulder. Say that, okay, I'm examining the right shoulder. There is a loss of contour. There is wasting. You need to say exactly where the wasting is. For instance, it's a wasting of the area of the pectoralis major or the deltoid. And then you go behind the patient. You go around the patient, go behind the patient and say that, okay, there is wasting of the suprascapular fossa, or there's wasting of the infrascapular fossa. And you can add on that there's wasting of suprascapular fossa indicative of a supraspinous wasting, or infrascapular fossa suggestive of infraspinous wasting. And then if there are scars, say that there is a scar of a deltopectoral approach, or there's a scar suggestive of an arthroscopic procedure. And then that's end of inspection. You go back to the front or to the side rather, and now do the palpation. So in palpation, what you essentially palpation, you look for tenderness. You look for tenderness at the sternoclavicular joint, along the clavicle, the AC joint, then the subacromial space, and you speak as you go along, and then you go into movements. So movements, always you start off with active movements. You ask the patient to keep both the arms in front with elbows straight, try to move it forward as much as possible, both elbows at the same time. And then you can, as the patient does it, you can say the patient has got this much of active range of motion. And once the patient says that, okay, I can do it only until this much, you hold it and try to get some passive range. So in a rotator cuff tear, I'm not speaking of rotator cuff arthropathy, this is a pure rotator cuff tear, you will get some more passive range of motion. And then as you do that, you say that, okay, I get more passive range of motion. And if you get more passive range of motion, you don't need to bring it up until 180 degrees, because you got the information that you got further passive range of motion, so that's not a frozen shoulder. You got one hand over the patient's shoulder, you don't get any crepitus. So now you know that it's not a rotator cuff arthropathy, it's not a glenohumeral osteoarthritis. So all these you verbalize as you go along, and then the examiner knows that, okay, he's thinking as you're examining the patient. And then you go into the abduction. You ask the patient to abduct, and again the patient does it actively, and then after the patient has finished doing it actively, you do it passively to see how much more you can get it. And as I mentioned, you don't need to get it until 180 degrees, because you get the information you get after doing a bit more of passive movement. After that, you go straight away to the special test. You start off with the supraspinatus, in fact, not the subscapularis. You start off with supraspinatus empty can test. You just need to do one test each for all in each of the rotator cuff tests. So supraspinal test, you do the empty can test. You say that, okay, this patient has got a weak, I'm doing the empty can test, it's weak when compared to the other side, so the empty can test is positive, suggestive of supraspinal stare. After that, you go on to the infraspinal test. The infraspinal test, you test with the arm at 0 degrees of abduction. You ask to external rotate as shown in the picture here, and then you do both sides simultaneously, and you say that, okay, the external rotation is weak, so I think that's infraspinal is also torn. So after that, you go to your subscapularis. Subscapularis, there are 3 classical tests, and it's mainly for the MCQ exam. You got the belly press test, where you ask the patient to hold both hands. In fact, you keep both hands in front of the belly, ask the patient to bring the elbow forwards, you hold the elbow from front and try to push it back. And that's how you do the belly press test. And then you can say that, okay, patient is weak on this side, must be having a subscapularis stare. That's it. You don't need to do further tests like the lift-off test or the bear hug test. So for the MCQ purpose, you need to know the lift-off test, the Gerber's lift-off test, which is, again, the hand goes behind, because in lot of this pathology, the patient will be having a lot of internal rotation problems, and patient would be having trouble going onto the back, and also, like, you waste a lot of time doing that. Patient will try to do it, you waste a lot of valuable time. And bear hug test is something which has also been prescribed. You never do it, but it's better to know that. Here you bring it onto the top of your shoulder, try to press down, and you resist, and the patient is weak. So now you're done with the rotator cuff test. In fact, the teres minor is also there, and that's mainly for the MCQ purpose. You don't test the teres minor for the practical exam, because it's very hard to isolate the action of the teres minor, and you don't do anything about it. But for the exam, for the MCQs, it's a favorite question, where something called the hornblower sign, where you ask the patient to abduct 90 degrees and external rotate 90 degrees, and you ask the patient to hold it there. After some time, if the patient's teres minor is torn, the hand goes in front, and that's called a hornblower sign. And after you've done the special test, you go on to the axillary nerve. It's very important you test for the axillary nerve. So when you're testing for the axillary nerve, mainly of 2 components. You test for the regimental badge area, the sensations, number 1, and also you look for the deltoid. You need to look for both. And then you screen the cervical spine, because that's the important part of the exam, because there's a safety issue in it. So that has to be, the moment you say, I'm going to screen the cervical spine, they'll say, okay, that's fine, it's normal. But it's important for you to tick that box by saying that I'm going to examine the cervical spine. So essentially, when you reach until there. So in examination, you should reach until this point by the 3.5 minute mark. So whether you score a 6 or a 7 depends upon how much finesse you reach until this level, and whether you're being able to detect a diagnosis as you go along with the examination. So once you reach a diagnosis, you've definitely reached the 6.5 mark there. And now examiner will ask you, what do you want to know next? So you need to say that get radiographs, AP axillary, outlet views, usually not done, but you can, if needed, you can say to assess the chromium. So the X-ray, the radiographic features of rotator cuff pathology, none of these signs are highly specific, but these are signs which are indicative of rotator cuff pathology, like dorsal sign, which is shown here, the arrow there, you find sclerosis on the undersurface of the acromion, and cystic changes in the greater tuberosity, calcific tendinitis, a type 3 acromion, which would be a hooked acromion. So all these are the X-ray features which you can see in a rotator cuff tear. And in chronic rotator cuff tears, you can get proximal migration of the humeral head, and then you get a break in the Shenton's line, and a proximal migration of the humeral head, which can be quantified when the acromial-humeral distance is less than 7 millimeters. So whenever you say an investigation, the next question would definitely be, what do you expect to see? So it's always good to know what you expect to see, rather than just saying that I'll take a radiograph, AP and axillary review. You need to know what you expect to see. They'll show the X-ray, then they'll ask you what next. I also want to take an MRI scan. MRI scan is the diagnostic standard. So obviously, next question would be, in fact, it's better for you to say, I want to take an MRI scan to know these things, rather than wasting a few seconds asking why. So the MRI scan is basically to assess the tear size, to know if it's a full thickness or a partial thickness tear, the shape and degree of retraction. So if you reach the 7 mark level, then they might go into the PATE classification, which will be coming short time later. And the second purpose of doing MRI scan would be to assess the muscle quality. There is this Coutelier classification. If you answer all those, you're definitely on the 7s. And yeah, so and then in Coutelier classification, it's basically based on the fatty infiltration of the cuff in an MRI. And then you're also looking for the medial biceps tendon subluxation, which is indicative of a subscapularis tear. That's also an MCQ. You can get it either ways. That you can get an MCQ describing, like, you got a biceps tendon subluxation medially. What could that be? Then it could be a subscapularis tear. Other way around, like a picture of a subscapularis tear. What else do you see? Then the answer would be a middle biceps tendon subluxation. And then there is this fourth point. It's better not to say that, but in case someone probes, you can say that because it's too much theoretical. There's something called a tangent sign. You can see here in the picture that normal, when you draw a tangent along the superior border of the scapular spine, you get a portion of the supraspine that's crossing it. Whereas when you get a chronic tear, so you can see that when you draw a line tangent along the superior border of the scapular spine, the sagittal MRI, the supraspine does not cross it. So, and then I'm coming on to the PATE classification. So, if it's a shoulder, you can get this question only if it's examined as a shoulder surgeon, obviously, but it's good to know that. So the amount of the PATE classification is based on the amount of supraspinatus tendon retraction in a complete tear. So stage 1 is when the tendon is near the insertion, near the greater tuberosity. Stage 2 is when the tendon is retracted to the level of the humeral head, and stage 3 is when the tendon has reached the level of the glenoid or proximal to it. And coming on to the Coutelier classification, it's an MRI-based classification, whereas it's grade 0 when you get normal muscle, and grade 1 when you get some fatty streaks in the muscle. Grade 2, you get more muscle than fat. 3, you get equal amounts of muscle and fat, and 4, when you get more fat than muscle. Essentially, the Coutelier classification is for looking on to the fatty infiltration of the muscle, which shows the chronicity of the tear, the quality of the tear, especially in the context of a chronic retracted tear. And then if you want, you can say that, I mean, the other options would be to do an ultrasound examination. The uses of doing an ultrasound is it's a dynamic assessment, but the problem is it can operator dependent, and it's similar sensitivity, specificity, and accuracy when compared to an MRI scan. So if you got this rotator cuff patient, it's better to take an MRI. I mean, for example, I would say that I'll go for an MRI scan because I can see for the fatty infiltration, I can see for the muscles, all those bits you can say. And also you can say ultrasound can be operator dependent, but there's no harm in saying that I can go for an ultrasound. If someone asks you what are the risk factors for a cuff tear progression, you can say that the age more than 60 years, then the tear severity. If you got a full thickness tear, then the chance for cuff tear progression is higher. The size of tear, when it's the medium sized tear, it's got more chance of cuff tear progression than when it's a small sized tear. Smoking has a lot of other instances as a risk factor for cuff tear progression. Hand dominance, if it's a dominant hand, there's more chance. Fatty infiltration, family history. Family history is considered to be a risk factor for cuff tear progression. So once you've gone through the MRI scan, so the next question, what are you going to do for the patient? These are the goals essentially for surgical treatment. That is to reduce pain and disability, to reduce the risk of tear progression, and number 3, to reduce risk of cuff tear arthropathy. So whenever you answer a question for treatment, it's a good strategy to say that the goals of treatment are this. And as you should always, you start off with conservative measures. You say that I'll try the conservative line of management initially, and then which include, you should say that it includes what? You shouldn't wait for the exam to say that what are the conservative measures you're going to do. So you got physiotherapy, which is the first line. The aim of physiotherapy would be to strengthen the muscle space, scapular muscles, the muscles around the shoulder, to improve the posture and the biomechanical axis of the shoulder. Steroid injections are the second line. And you can also give NSAIDs. They're useful in the short term for pain relief, but there is no functional improvement. And the last point there, the suprascapular nerve blocker ablation. So that can be kept as part of the armamentarium, because in end-stage rotator cuff disease or arthropathy, where the patient is not fit for surgery or patient has declined surgery, that is an option for a suprascapular nerve blocker ablation. So that's also part. You shouldn't say that I'm going to go for suprascapular nerve blocker ablation in the first instance as part of the conservative measures. Stick on to the step 1, 2, and 3 and keep that according to the scenario. Speaking about surgery, rotator cuff repair, open versus arthroscopic surgery, you got the UCUF trial published in BJJ in 2017. So it's good to know that, because if you speak about that, you're going on to the near the 8 territory. So open versus arthroscopic rotator cuff repair in patients more than 50 years with a degenerative rotator cuff tear. So they found that there's no difference in clinical outcome at 2 years. But the rate of re-tear, the re-tear rate was high in both open and arthroscopic groups for all sizes of tears and ages. And this adversely affects the outcome. So in essence, the UCUF trial showed that open versus arthroscopic both have got equal results, but the re-tear rate is high in both instances. And of course, this re-tear adversely affects the outcome. And now, in the rotator cuff repair can be with or without a subacromial decompression. So there is limited evidence that performing a subacromial decompression along with a rotator cuff repair will significantly improve patient's outcome. So that's something to know, though we keep on doing it. And then again, a single row versus a double row or a suture bridge technique. No one is going to ask it to go into that level, because if someone asks you about that, it means that you're scoring really, really high. So, but it's good to know that in general, a double row repair seems to perform better in the current literature due to a lesser re-tear rate, a larger surface area of contact, improved biomechanical strength due to multiple points of fixation. So in fact, I know this is a very controversial area, but for FRCS, even if this comes up in the Viva, it won't go beyond this level. And then this is important thing, the massive retracted rotator cuff tears, because obviously if you get a patient like that, highly likely to get that, you need to know the treatment options. So you need to be able to list the treatment options. Number 1 would be physiotherapy like deltoid rehabilitation. Number 2 would be a partial repair plus or minus debridement. Number 3 would be tendon transfers. So you can do a latissimus dorsi transfer for a massive retracted rotator cuff tear, but that needs an intact subscapularis function. And you can do a pectoralis major transfer in a chronic subscapularis tear. So that's an MCQ, that in a chronic subscapularis tear, what's the type of tendon transfer? That's a pectoralis major transfer. And then there are the other options are a synthetic patch like Graf jacket, where it's essentially denatured, demonized human skin that you use as a synthetic patch. So it's healthy muscle. You do it when the patient has got a healthy muscle but poor tendon quality. Options would be a superior capsular reconstruction. The principle of a superior capsular reconstruction is it restores the normal superior anatomic restraint of the humeral head. Graft for restoring the superior anatomic restraint of the humeral head, and it relies on the deltoid for abduction. It essentially prevents the humeral head from migrating proximally. Then you got the in-space balloon, which essentially is you place an inflatable balloon, which is a deflated balloon, which is inflated with normal saline in the subacromial space. And the principle of that is it depresses the humeral head, and by doing that, it enables the patient to exercise and allows other muscles to take over function of the cuff. So that's an option to speak about. You don't need to know in detail about all this. Just need to know what the options are and how each one would help. And then, of course, a reverse shoulder arthroplasty is something which you want to do as a last resort when there's a patient who's got a painful rotator cuff, insufficient and non-functioning shoulder in an older patient. So it's very important to mention, okay, these are the options. I'll go for conservative management, for physiotherapy, for deltoid rehabilitation. My surgical options would be a partial repair plus or minus debridement, tendon transfer, synthetic patches, superior capsular reconstruction, in-space balloon. And if everything fails, as the patient it's not non-functioning shoulder, and in an older patient, I go for reverse shoulder arthroplasty. And probably that will be the end of where the Viva ends. And also, I doubt it would go beyond this, even for in the clinical cases, because by that time the 5 minutes mark will be done. So this is essentially what you need to know for the FRCS exams. And if you go until this level, then you're probably scoring until the 7s and 8s. And how you reach the 6 or 7, as I mentioned, is how well you go along the examination and you explain, verbalize, vocalize examination findings, and check the diagnosis as you go along confidently. The way you examine should seem like you've done this a lot of times. Thank you. I'd be happy to take questions in case you have any.
Thank you, Ranjit. That was an excellent presentation. It's very nice to hear this from you, as you recently passed the exam. You've taken us through the journey of rotator cuff problems from theory part to Viva and clinical. And I think you pitched your presentation at the right level for the FRCS exam. And he advises all participants to focus on being systematic in your answer, have clear classification systems. You don't need to go in a lot of depth, clearly, but you have to have a system to follow. And it just, you have to look like you are a smart candidate to the examiner, have a right approach. You'll be unlucky that you have a shoulder examiner, but you could be. But if a non-shoulder examiner, if you follow this nice approach Ranjit explained in this presentation, you will really impress them. You'll even impress a shoulder specialist, subspecialist surgeon. So it always helps. So that's thank you, Ranjit. I think this covers the whole aspects of the FRCS, all 3 parts of the exam. So I think this presentation could be a reference really to all future candidates. Question, if you don't mind.
Yeah.
You mentioned in your treatment options using synthetic graft and graft jacket. Can you tell us a bit more? I mean, examiner might say, what is graft jacket, or what is this? I mean, is it synthetic, or is it is allograft, or what type of graft is it?
So essentially, the graft jacket is it's denatured human skin.
What skin? Whose skin?
Yeah, it's denatured human skin, because it's human skin which is denatured. So it's essentially sort of an allograft which is denatured.
So it's not. Would it still be?
After you get this, synthetic patches can be it's allograft, and the various options in allograft is you got because I think you can just say that it's collagen, it's denatured human skin which has been deimmunized, and all that they want.
Can I?
Thank you. Yes, Mohammed is. We would like to hear from you. Your comments overall about rotator cuffs, and any comments you have, please.
Yes, it's just that's a very good presentation, Ranjit, and I really enjoyed it. And as for us, I think that's good to have it on this website because it is very educational. Just one thing, graft jacket is a commercial name for the allograft produced by Right Medica. So I won't use the term graft jacket. And we've written a meta-analysis on different scaffolds used in biological substrate components like for augments and so. And there are 3 types. You can just use, say, allograft or autograft. Autograft was the original one described by Itoi. By Mihata, from Japan, and there is the allografts like graft jacket, and there are the ones manufactured by Arthrex as well. Also, there is, and it is in this meta-analysis and in other studies, now they proved that this is associated with superior outcomes, but it's still controversial. Also,
so can I ask a question, Mohammed? So graft jacket is a brand name. It's not...
it is a brand name.
Absolutely.
It's a brand name for Right Medica.
So what do you suggest we should use for the exam? A candidate should use?
Patch. I would say augmented patch. Like patches would be enough.
Patches, and then they can ask you further. You could explain what the patch is composed of.
unless the examiner is a shoulder surgeon, I don't think they will go in depth. But
No,
you can
no.
also say that recent evidence supports that it is associated, doing augmented repairs in those patients with bad quality tendons are associated with improved outcomes recently. And that's one of the
I do agree
studies.
with Mohammed. Yeah, I mean, graft jacket is something you shouldn't be putting there. I think it's my mistake because it's a strict no-no to come up with a commercial name. My
Yes.
apologies for putting that there. It's always good. Yeah,
Yes. So if you want to use the word graft jacket, you can just say a cellular human dermal matrix augmentation, because that's, or dermal matrix augmentation, or dermal patches. I think that's if you want to use a term. Supported the use of graft jacket was published in Arthroscopy 2012. It is an RCT. So it's really a very well conducted. The thing also, instructions, there is also, I think it's a nice guidance now that it can be only done as part of a trial nowadays, because there isn't enough evidence validating it. Although many surgeons are using it everywhere, but it is now suggested that you now can only use superior capsule reconstruction as part of a clinical trial. So I would, so if it is a repairable cuff, you can consider options like superior capsule reconstruction as mentioned, or tendon transfers, either lower trapezius transfer or the lat dorsi transfer for posterior superior repairable cuff tears, or even arthroplasty, which would be easy to discuss and in details, I mean. So just choose something you're confident talking about.
Thank you, Muhammad.
Yeah, I mean, it's true about the dead man's angle. It was described by Burkhardt, and it's essentially what Burkhardt did was it's essentially the angle in which the suture anchor is inserted into the footprint. So it's, I mean, 45 degrees to 90 degrees, what was being described, and the dead man angle is essentially the 45 degrees, which was recommended by Burkhardt. So that's essentially what we are looking for.
Thank you very much. I think that was very good. I think thank you very much, Ranjit, and thank Muhammad for your input. It was a fantastic presentation. I've learned a lot, and I am going to have the pleasure of revisiting this to edit it and put it on the YouTube channel for everyone to see, especially for those people who didn't have the opportunity to attend today. I just want to remind people you'll be entitled to have a CPD certificate, 1 credit from Royal College of Surgeons. Please get in touch with me via the Telegram group or Facebook if you like to have one. I think we are reaching 8 o'clock now, so we'll probably will finish the session. Mentors need to rest now. So thank you everyone for attending.
Thank you.
Thank you. Thank you for all the participants. We had 45 participants this evening. So thank you to every one of you. And I hope you all learned something useful for your exam from this session. And good night.
Bye-bye.
Bye.
Thanks for us.
Bye.
Thank you.
Thank you.
Thank you, guys. Thank you.